Okay, hello everyone. Good morning, good afternoon, good evening. My name is Robert Martin. I'm a scientist at the Alliance for Health Policy and Systems Research, and one of the co-editors of the WHO Bulletin Theme issue on PHC. We're delighted that you're joining us today to kick off this series of webinars on PHC Research Week. Before we get started, some quick housekeeping. If you have a question for any of the panelists in our discussion today, please use the Q&A button. You should be able to see it at the bottom of your screen. Our session will be recorded and made available after the webinar finishes on our website. As I mentioned, today's session is the first in a series of PHC Research Week webinars. Today and now, we're launching the WHO Bulletin Theme issue on PHC. Tomorrow, Thursday, we will consider and review emerging evidence from PHC research. And Friday, we'll begin to move from research to policy action and consider the future of PHC research. For today's session, we'll start with some opening remarks from Abdul Ghaffar, the Executive Director of the Alliance for Health Policy and Systems Research. We'll then have a keynote address from WHO Director General Tedros. We will then move on to two panels. One will be moderated by Shannon Barkley with Soraya Dalil from the PHC Special Program and Ed Kelly, the Director of the Integrated Health Services Department. I'll moderate a second panel with some of the authors from the themed issue. Without further ado, I'd like to now hand it over to Abdul Ghaffar, the Executive Director of the Alliance for Health Policy and Systems Research. Ghaffar, over to you.
Thank you, Robert, and welcome, colleagues, and my special welcome to Dr. Soraya Dalil and Dr. Ed Kelly, the two colleagues who have been working with us over the last few years to build the field of policy and systems research or implementation research for the primary health care. As Robert has said, it would be like few things which we are going to share. The one thing I just want to build the case that why PHC Research Week now, I will explain what we have done together initially with the Ed Kelly's team and now with the Shannon's Soraya team on the PHC Research. And then as you all may or may not know that the Director General has established a WHO special program on the primary health care, which is a flagship program of the DGWHOs. The COVID-19 has made us very clear that if we really want to succeed, then we need to strengthen our primary healthcare systems, but also needed local knowledge to improve the health system performance and the primary healthcare system strengthening. So I will share a few slides. So this is the alliance, what we have done together with the Ed Kelly's team initially, as I said. We commissioned and conducted like 20 country case studies on premises, and I see my colleague Etienne is also on the panel, who has been the lead author and the lead person on this thing. And then we worked with Shannon and Ed Kelly and other colleagues in WHO, where we were working on the Astana Declaration, and we made sure that it's both in the declaration and the operational framework. Why research or the local knowledge or the learnings are important to work into the countries to achieve the USC. We also commissioned a special issue of the BMJ Global Health in September 2019. We did a lot of work which was but also with other colleagues to build the field of PHC research to achieve the USC. Then we have worked with other institutions and the countries to build further the embedded PHC research consortium, especially with the Ariadne Lab and the Gates Foundation. Then we also commissioned a book which is on, I will show, this is like looking at different countries, how they have done from 1978 to Astana Declaration. And today, as you know, we are launching the WHO Bulletin on the primary health care. Next, please. So these are, as I mentioned, the premises case study. These are the 20 countries, which is like primarily are like Asia, South and Africa, but also some countries from the Latin America and the Middle East. There, like it is all on our website, but it was analysis of primary healthcare system in those countries. We wanted to inform the national health plans and health system reforms, covers key aspects of primary healthcare systems, including policy development and the implementation. Next, Jeff. So this is like, I think almost all of you know what is the Astana Declaration and operational framework for the PHC, but we just wanted to highlight that these are different things the WHO at the headquarters had worked over the last couple of years to build further the field of primary health care. Next, please. So then the BMJ Global Health, this is where we worked with Ariadne Lab, Gates Foundation, but also with the senior leadership of the Gavi, and looked what are the different ways to improve the primary healthcare, especially what is the role of the communities and the partnerships if we really want to make the PSC a success story. And this was the special issue of the BMJ Global Health. Next. So then we have done a priority setting exercise for embedded research on primary health care, primarily with the two regional offices of the WHO, CIRO and WIPRO, but we also collaborated with the UNICEF and the United Nations University that what sort of research priorities are required if you want to do more and more primary healthcare research, which can respond to the needs of the national policymakers and the program managers, but also to the regional leadership of the WHO, especially in Southeast Asia and the Western Pacific region. And that work is going on. And now we have identified the priorities, which are basically the priorities of the national policymakers. What are the research gaps they think are important if we want to achieve the USC or the PSC systems are going to be stronger. And now we're working with Gavi and other colleagues to design those research studies over the coming years. Next, please. And this is a special issue which we will have a more discussion and more information about this from the two panels, which are going to be following up once I have finished. I think the one thing we also mentioned, this is the book, Achieving Health for All, which we have commissioned, and it has been like contributing how the primary healthcare systems and reforms had worked over the 40 years from 1978 to 2018. And that is what we are trying to understand, what changed over the last 78 to 2018, and what are the learnings which we can have. And this is a book about that which we commissioned, and it was recently launched by the Johns Hopkins University Press. And it's available on our website, and there are also some social media events, including a YouTube out of this book. Next, please. So now I would like to, DGWHO has very kindly written an editorial into this special issue, planning to join us in this webinar, but he has to have another priority meeting at this point. But he has kindly sent us a message on this special occasion on the launch of the WHO Special Bulletin and the PHC Research Week. Jeff, can we play the message from the Director General, please?
Dear colleagues and friends, the 1978 Declaration of Almada marked a paradigm shift in global health. It moved healthcare from the traditional hospital-centric biomedical approach to one focused on meeting the health needs of communities and addressing inequities. The 2018 declaration of Astana affirmed primary health care as central to the achievement of universal health coverage and the health-related sustainable development goals. And it defined the three core pillars of primary health care. First, primary care and essential public health functions at the core of integrated health services. Second, multisectoral policy and action. And third, empowered people and communities. The COVID-19 pandemic has further highlighted the importance of primary health care. Leadership, the strengths of health systems, and the public's confidence in those systems have been determining factors in the quality of the response to the pandemic. But globally, investments in secondary and tertiary care tend to outstrip those in primary health care. Moving from the promise of primary health care to implementation requires addressing major hurdles, including funding, monitoring, and research. I warmly welcome this special issue of the WHO Bulletin, which presents important new research on primary health care. To support member states, WHO has recently established a special program on primary health care, which brings together expertise across the various technical areas of WHO at all three levels. And we will continue working with all member states to strengthen primary health care at the foundation of a healthier, safer, fairer, and more sustainable future. I thank you.
Robert, thank you, and back to you.
Thanks, Gafar. At this point now, I'd like to introduce Shannon Barkley. Shannon is the Technical Officer for Primary Healthcare Services in the Evidence and Innovation Unit of the Special Program on PHC at WHO. She's also one of our co-editors for the special issue on PHC. Her current work is focused on the implementation of the operational framework for PHC. We're really glad to have her here today. Shannon, over to you.
Thank you, Robert, for the kind introduction, and also for the excellent demonstration of the work that's been going on in this area. We are absolutely thrilled to have co-sponsored the special issue of the WHO Bulletin on Primary Healthcare, Realizing the Vision with the Alliance for Health Policy and Systems Research. And I just want to start our session by saying a huge thank you to all the contributors and also to the researchers on primary healthcare worldwide who toil day in and day out to bring the evidence to light in order to enable the strengthening of primary healthcare globally. Primary healthcare and research have been positioned very prominently in recent political commitments. We've seen in the Declaration of Astana and the accompanying World Health Assembly resolutions that adopted that declaration, as well as the political declaration of the UN General Assembly high-level meeting on UHC, that the importance of primary healthcare in achieving universal health coverage and the health-related sustainable goals, development goals, has been highlighted. And I think quite excitingly, research has been explicitly mentioned in both the Declaration of Astana, as well as within the operational framework on primary healthcare. And it's been made clear that though we have lots of existing evidence around primary healthcare as the approach that enables us to achieve health for societies in the most equitable, effective, and efficient way, that we need more evidence, particularly context-appropriate evidence, to enable the continued evolution of primary healthcare to address the needs of the 21st century. The coronavirus pandemic and its further effects have highlighted the importance and centrality of primary healthcare, both in terms of maintaining essential health services, responding to the pandemic, and also building community confidence in terms of the public health measures that are needed to be implemented to stop the ravage of this pandemic. In many settings, we know there remain persistent gaps in contextualized knowledge and in capacity for research, as well as knowledge of locally acceptable and adapted solutions. This is exacerbated by lack of political will for primary healthcare, lack of emphasis on primary healthcare, and chronic underfunding, not only for primary healthcare, but also for the research that underpins it. The launch of this issue represents a first step in the joint work of the Special Program on Primary Healthcare, the Department of Integrated Health Services, and the Alliance for Health Policy and Systems Research toward helping to fill these gaps along with all of you online. And it reflects WHO's strong commitment to accelerating progress on primary healthcare. In just a very short while, we will be joined by Dr. Soraya Dalil, the director of the new special program on primary healthcare, and also by Dr. Ed Kelly, the director of the Department of Integrated Health Services at WHO headquarters. I will remind you all to please use the Q&A function as we move forward to enable us to have the best, most fruitful and productive back and forth in this conversation that we possibly can. I also want to just mention briefly that we truly appreciate apologies. I was just getting a text message from Soraya to let me know she's here. So with that, I'll just ask Soraya to go ahead and turn on her camera and we can switch from sharing. Jeff, if that's all right.
Hello, Shannon. Hi.
Hi, Soraya, and welcome. We're thrilled that you're here.
My camera is on.
Wonderful. Colleagues, as mentioned, this is Dr. Soraya Dalil, the director of the new special program on primary healthcare at WHO. We just heard from the Director General a bit about this special program and why it was started. But Soraya, I wonder if you could share from your perspective, why now has WHO created a special program on primary healthcare and what exactly will it do? How will it work?
Yes, and good afternoon, good morning, colleagues. First of all, thank you very much, Dr. Shannon Barkley, for this introduction. And I'm very glad to be among you this afternoon. Thanks to all of you who have find time to connect and be part of this discussion. Primary healthcare is not a flashy new topic, but every challenge we face reminds us to go back to the fundamentals. And those fundamentals are equity, human rights, solidarity, social justice, people and communities, engagement and empowerment. And those fundamentals are at the heart of primary healthcare right from the beginning, right from the Declaration of Almata in 1978. We have enough scientific evidences that primary healthcare-based health systems are effective, efficient, and they deliver care in an equitable way. So the focus on primary healthcare has been renewed since October 2018, when Global Health Partners, WHO and UNICEF came together in Astana and renewed their commitment in primary healthcare. And they released the primary healthcare vision for 21st century. So it's back to the fundamentals, back to what it makes sense. It's back to equity-based and people-centered approach. What we are going to do, this is a new program. This is established. The primary healthcare is not a new agenda as such, but this time the Director General has been dedicated a program, a special program on primary healthcare. It will not be a vertical program as such. It will rather be an enabling program, a program that will add value in the sense that it will connect the work of the general program of work of WHO. For those of you who are aware of this, WHO has triple billion priorities. It's making the world safe, serve the vulnerables, and promoting health. And the primary health care based on those principles of equity and social justice and solidarity is the connecting drive, is the connecting platform among those strategic priorities and programs of WHO. It's also important to remind you that in the WHO's constitution, in the very first paragraphs of the constitution, the right to health has been reflected as a fundamental right of all human beings, regardless of race, religion, political beliefs, economic or social conditions. So that's one. So a unifying connector within the WHO. And WHO, when I say WHO, it means headquarters as well as the regional offices and country offices. It also takes us to our principal approach, that is primary health care is the backbone, is the engine, and it's the cornerstone for universal health coverage and for sustainable development goals. Second, the added value of this program is its focus on the country level impact. Last week, the resumed World Health Assembly supported the primary healthcare operational framework. And that is that there was an immense call and demand from countries, from states, to assist them in rolling out of the operational framework in the countries, and to provide a one-stop mechanism for country support with regards to the primary health care. The other added value of this program is the measurement, this PHC measurement. Dr. Barkley earlier said that there's a chronic, long-standing underinvestment in primary health care. There's various reasons for that, and one reason for that is because of data and measurements and evidences to engage with the policymakers and decision makers at the national level about investment in primary health care. We have high-level political commitments on UHC last year. We have Declaration of Astana and a number of other resolutions, declarations, and decisions at the level of states with regards to primary health care and universal health coverage. However, in order to use those commitments, high-level political commitments at the national level, and change that or use that as a drive for actions to support primary health care, we need data and we need evidences, and including evidences about people who left behind. And the other added value of the program is to keep the PHC renewal agenda on the global health agenda. It's to ensure advocacy and policy and partnership on primary health care. This is a collective agenda. This is an agenda that has multi-stakeholders. This is an agenda that acknowledges civil society and community-based organizations, as well as partners and financing institutions, academia, and others. And here we are to continue on that policy and advocacy agenda. So I would like to stop here and back to you, Shannon.
Many thanks, Soraya. I think the way of working and the importance of this program now more than ever is quite clear. In the workings of this program, can you say a little bit about how the knowledge generated both from research as well as specifically perhaps from this special issue of the WHO Bulletin might impact the way of working of the special program on primary health care?
Yes, the research part of the program has been, first of all, a great experience. One of the first activities that the special program undertook with great support from our colleagues from Alliance on Health Policy and System Research, as well as the Science Division of WHO and our regional offices and country offices colleagues. So for us, first of all, the evidence, measurement and data will be one pillar of the program. That will be the hardware of the program, or the campus of the program that shows us where to go, and especially with focus on people who left behind. We learned a number of things from that, from this undertaking. One is a country-driven and bottom-up approach in research and knowledge generation, capturing local initiatives and local innovations on primary healthcare, and also engaging with frontline professionals and workers on primary healthcare to shape that research agenda. I'm coming from government experience. I worked for the last 10 years with my government, with my country government. And I know that in a number of countries, research is very much top-down. Research is very much donor-driven. And research takes into account very little about local needs, local demands, and local priorities. So we will help countries to embed research on primary health care as part of their routine work. Back to you, Shannon.
Many thanks, Soraya. We're actually starting to get some comments in the Q&A, so please keep them coming. We have just a few more planned questions for Soraya, and then we'll turn over to your questions. So please share your inquiries with us. Soraya, I wonder if you could share what you see as the most important research gaps for PHC to be filled.
Can you say it again, Shannon?
Certainly. If you could share a bit about what you see as some of the most important knowledge or research gaps to be prioritized in order to be filled.
The research priorities, first, we will build on the experiences that we got in our exercise and in our work in two regions, in WIPRO and CRO regions. And the research priorities will remain with regards to community involvement and community engagement, the multi-sectoral action and multi-sectoral policies, and what drives those, creating that environment for multi-sectoral policies to take place and for the multi-sectoral actions and decisions to take place, and a number of research areas with regards to essential public health functions, accountabilities, people's participation in accountabilities, and accountability mechanisms.
Thank you, that's very clear. And one last question before we turn to the questions from our audience. Based on your experience in government and also on this new role that you have, if you had a magic wand and could improve one thing about the relationship between research and policy, what would it be?
Okay, I will support the research bodies, whether that's national institutes or research departments or research institutions in the countries in terms of their technical capacity, in terms of their architecture, in terms of their research capacity. And I think that that's very, very important, because countries need that one. It will take a lot of time. It takes really sustainable support and political commitment to do that, but it's very much feasible. And then use the data and research findings into the decision making. put that into the table for discussion and for decisions, and create a new culture, embrace a new culture for use of data and evidence-based decisions. That shouldn't be only at the level of the ministry or national level. It should be at the level of health facilities. It should be at the level of subnational or provincial departments. It should be at the level of each thematic departments within the ministries. And it should also be at the level of policy discussions, resource-related discussion with the Parliament and with the Ministry of Finance.
Thank you so much, Soraya. We've received some very engaging questions from our audience. The first one is from Lindy Ann, and she thanks you for your presentation and asks if you could provide some additional details on how WHO plans to engage with civil society organizations to increase the body of evidence around primary healthcare in different contexts.
Yes, we will use the existing platforms to engage with the civil society and to partner with them, including the UHC Partnership Civil Society platform, which is a well-established mechanism bringing many civil societies around UHC agenda. We will also use the Global Action Plan SDG3, and we are part of that as one of the accelerators within the Global Action Plan SDG3 multi-agency work. And there also is a civil society work, and we will be working with them. So these are the few examples that we have now engaging with the civil society.
Thank you very much. Another question from our audience, Dr. Shazia asks how we can support new researchers in low and middle income countries to do PHC research.
Can you repeat, Shannon, please?
Of course. This question is from Dr. Shazia, who asks, how can we support new researchers from low and middle income countries to do PHC research?
Yes, we in our program, the evidence and innovation pillar of the program has a research component, and through that unit we will work with our regional offices. That's the way the WHO is structured, and with country offices to support research around PHC in low and middle income countries. And I should have told you that for us the work has been very much on low and middle income countries to capture those local innovations at the low and middle income countries where the research on primary healthcare has not received enough focus and attention. The way to engage on that is through WHO country offices and through ministries of health.
Thank you so much, Soraya. I know that you have other commitments, but I hope you'll be able to stay on with us for a few more moments. We have a few more questions from the audience. I'm also aware that we've been joined now by Dr. Ed Kelly, the Director of Integrated Health Services. And so Ed, I'll just ask you to turn on your camera so you can join us formally in this discussion. And as you're doing that, welcome. As you're doing that, I wonder if you could answer for us, what does the Department of Integrated Health Services at WHO do? And how will this special issue of the WHO Bulletin impact some of the ways of working at your department?
Yeah, thanks, Shannon, and thanks for having me here. And it's a real honor to be here, of course, with yourself and with Soraya and with Dr. Ghaffar and everybody. It was really, although I would have liked to have left my holiday background up for a little bit longer there, I couldn't stop but put up behind me, as you saw, the banner I think you created for the great meeting we had that really kicked off the push we made on primary healthcare in the lead up to the Astana conference. And I think in a lot of ways, if we go back to that meeting that we had looking at improving the quality of primary healthcare, which is really work that came out of the primary healthcare performance improvement work, joint work with the financing team, with the data team, and obviously with our group on service delivery. I think what the reason that this issue is so important, and then I'll come back to the department, is that it really tried to tackle the full scope of primary healthcare, and also, as we talked about it in Astana, and also to tackle some of the full scope of the bottlenecks that exist there. I just finished, which is the reason I joined late, a session I had agreed to do with the World Economic Forum on health systems resilience. And the conclusion from all sorts of panelists and economists, a lead of global vaccine production at AstraZeneca, our Secretary for Health in India, was that if there was one thing everyone could put their money behind to increase health systems resilience, in this context where that seems to be the topic everyone wants to talk about, it would be around stronger primary health care for preventive, promotive, and also, of course, curative services, but really putting the emphasis on that preventive and promotive service. And so anyway, that's why I think the issue is so important. It really tackles this question of, it's not about health systems or essential public health functions. It's about the two of them that have come together with this approach that we've had. So for the department, without being glib, we used to say that anything that wasn't medicines, money, or workforce was in integrated health services, because actually you can put almost anything in there. And in the historical sense, we have had a very wide range of different service delivery programs. Now, the work of the department really focuses on what are the clinical services that countries need to be focused on in terms of delivering UHC, and how should they be organized? How do you quality assure them? So with the quality, the safety, the infection prevention issues, and then how do you monitor them? So those are our three core pieces of work, and we see ourselves very much as supporting the work that Soraya is leading on the PHC special program as kind of the capstone of the approach on all of that. So anyway, hope that answers the question.
Very much so. Thanks, Ed. In light of that, I wonder if you could share some of the major research gaps in those areas you just highlighted that are work for the department. What do you see needing to be the service delivery focus relevant to primary healthcare with regard to research?
Yeah, I think if this won't be comprehensive, but I'll hit maybe three sort of big highlights, at least for myself. If you look at clinical service delivery, we have, how should we put it? We have been very donor driven in the recent past at WHO, and in the end in the global, we're just a reflection of the global health architecture, as it were, around service delivery. So we've tackled health services, but particularly looking at, with the legacy of the MDG era, on communicable diseases, on HIV, TB, malaria, lots of very good and very applicable lessons learned, but they're also quite specific clinical services. We've done almost nothing on emergency services, for instance. We've done very little, as we've talked about before, on really investing in primary healthcare research. We have very, very little, and this outbreak is showing us, that shows us how to organize and deliver effective, safe, long-term care and nursing home care. That's I think a piece that's there. So looking at the sort of the integrated aspect of that service delivery, so across the continuum of care, that's a big gap. How do you make that continuum work for any given patient? A second piece, then, I would say, in the quality arena is really, for years and years we have spent, so two things there, we have spent time talking about sort of guidelines and the what are the most robust guidelines. We've done very little that looks at the best practice to actual practice gap. In my old agency, the Agency for Health Care Research and Quality in the US government, we used to say that the average was 7 years between one of our practice guidelines and then real change in practice. That's incredibly accelerated during COVID. It's a big opportunity where you have the remdesivir guideline is about to come out next week. That was, sort of months in the work, not years. So I think there's an opportunity there. So the translation on clinical guidelines to practice. Then the second piece on that is that in the quality realm, it's been a world of sort of pilots. We've been great at like piloting in 4 or 5 health centers in one part of Mali, an approach for quality improvement, but we haven't taken that to the policy level. So what's the policy environment for quality? And I think that's a big gap that we haven't done enough research on. And then finally, it's really on the metric side. And this is a big agenda for the special program we're planning to support on this, is really measuring service delivery, really looking at primary healthcare service delivery and the quality of it. We had a section in the monitoring report from 2019 looking at primary healthcare, looking at the quality, and there's very little you can say across countries. There's no global, anyway, you've heard me say this, so I'm repeating it for everybody else, but there's no global consensus measure set of quality of care, which is insane, by the way. So we need to get to that consensus, and we need to build up those indicators.
Thanks, Ed. Those are great insights. I'm going to turn now to some of the questions from our participants. And Dave Bashai asks, relevant to both your comments and Soraya's on community engagement and essential public health functions, he's asking how skills in community organizing and public health practice are not in most medical curricula currently. How are we going to transform a sickness-based workforce into a PHC workforce?
Yeah, great question. And I'll just forward that right on to Jim Campbell and the health workforce, Dr. Bashai, professor. But anyway, great to have you here. And I think this is something we even highlighted in the very good session that we had in Bellagio that you helped lead on and lead up to the Astana and elsewhere, looking at this type of question. At the moment, there are some promising sort of curriculum guides that are out there on this. We've tried to build it into some of the new curriculum guides we're doing on one of our other initiatives on patient safety. But that, I think, will be a big piece that needs to be there. I think there's also a major possibility, if you look at one of the initiatives we started partially for Astana, the Young Leaders Network for Primary Healthcare, actually the way that young professionals, and this was a group who was very wide ranging across, there were medical doctors, also nurses, also community health workers, also social workers, and wider. The way that they get information has become much more democratized and much more, you don't have like a separate sort of education virtual channel for doctors versus your social worker. So there's access, there's much better access. So I think that that will be in the immediate sense how we can ramp up much quicker. WHO Academy has a platform for this. We just need to really adapt some of the content that's out there.
Thanks, Ed. Fidel asks, first he thanks you for the presentation and then asks, what is the WHO plan to keep primary health care as an integrated part of the healthcare ecosystem, given that in some low and middle income country settings, primary health care can be isolated from other levels of care? Yeah,
I think that's that's actually a very common experience. I worked for years and lived in Niger, and like you had the disease programs in one part of the ministry, and then sort of the like the director of hospitals who spent most of his time at the flagship academic hospital in Niamey, and then the rest of the program sort of in a different part. And I think that separation, anyway, there's tons of reasons for that, some of which are probably our own doing at WHO, dating back to Alma-Ata and other things that we talked about in the lead up to Astana. But not without making everything about the immediate sort of last 9 months, but I do think that there's been a real acceleration in the understanding that if you look at countries that invested a lot on universal health coverage and had good UHC index numbers, actually they didn't do so well in the current outbreak. And ones that had, you take for instance, anyway, it's not a perfect example, but our colleagues in Liberia, where we spent a lot of work for Ebola and very good friends of the Deputy Minister, Chief Medical Officer, you know, they had a much stronger tradition of the integration of the public health and outreach services and also then the care delivery within the rest of the health system and the delivery of the disease programs. So I think there are actually some lessons that can come from the recent experience on this.
Great points. We have a reminder from Jerome that we can't forget about rehabilitation as being part of primary care. And I think that's something that we were really pleased to see explicitly mentioned in some of the documents around the declaration of Astana and the operational framework and relevant resolutions. So we are with you, particularly on the importance of rehabilitation as it relates to long COVID and also the prevalence of NCDs and aging. So we share that perspective, and you'll find that in a lot of the documents. We have another question from Leticia Campos from Brazil, who asks, in general terms, what are the main challenges and differences in providing primary healthcare between high-income countries and low and middle-income countries?
Yeah, I mean, there's probably a lot of different points you could bring out on this. I would say, I mean, anyway, my own personal answer would be the biggest gaps we saw and reported on a bit in the 2019 report was the big gaps in the foundations of strong primary healthcare. So in lower income countries, I mean, and obviously each country is different, and all these discussions we always have about, as somebody used to direct OECD's inter-country comparisons and then the US national reports, there's always more variation within a country than there is between countries. So you can, so anyway, but many of the listeners have that in mind. But in general, if you're looking at low income settings and higher income settings, the gaps are most pronounced probably on the health workforce side of things in terms of even being able to deliver effective essential services, you know, for instance, now during the outbreak, but also be able to ramp up services for COVID and start to prepare for a big vaccination campaign. There's just so many health workers out there, and you can't create a health worker like you can create a syringe of vaccine in a relative in the time period that we need it. And so that will be a big piece. Also, the second would be gaps in supply chain and the availability of those key medicines that you need at the front line, but not just medicines, also basic other equipment. Like this time around, we realized that we needed to care about PPE at primary healthcare and at community care settings, which we didn't before. And finally, I think one piece that gets not enough play, and if we all made a big push on it, it's a very good investment and it's very achievable, is around water and sanitation at primary healthcare levels. I've mentioned this to Shannon before and said it at the World Health Assembly, even myself, but when we made a great trip to Cambodia to look at their experience on primary healthcare, they had just made, and now things with COVID have been difficult to keep going, but in general, they had made a huge investment on primary healthcare, big investment on infrastructure, and a big new primary healthcare push. And when we visited all of these health facilities, the first thing people brought us to see, they said, look, brand new toilets, one for men, one for women, and a place to wash your hands. We have the best primary healthcare system in the world. So I think it's not, I mean, actually that's a big effectiveness jump that will reduce infections and all these types of things, but it also created a huge trust in those communities as well.
Thanks, Ed. I'm going to close out our time here with one additional question from Faraz Khalid from WHO MRO, who brings us back to the focus on research by asking, what is placing limits on the ability of the health systems to prioritize primary healthcare and integrated service delivery related research?
I think, it's it's a good question. It's a little bit multi-layered. I mean, one, I think there's a bit of history there. I think also in recent past, the prioritization of primary healthcare as a both as a clinical discipline and also a scientific researchable discipline hasn't been there, because it has seemed that like research and the big research findings were going to be in more disease-based research, which had to do with specialties, which had to do with big hospitals, which had to do with more research facilities. So I think that's one piece of it. I think also, although it's changing some in a number of countries, there haven't been dedicated institutions necessarily in all countries set aside national institutes of, for instance, primary healthcare, or sort of funding bodies that had within their strategy to fund research around primary healthcare delivery. And I think, honestly, the last piece, I guess, is just that it comes back to a little bit like why, as Shannon knows, why primary healthcare is actually one of the sort of least well-funded areas of WHO's own agenda, along with perhaps the $3 billion around sort of health of populations, is that the world just assumes somebody is doing it. So they just assume, hey, that's core business for WHO, right? Somebody must be giving them money to do it. So I think it's the same thing around the research agenda. People think, well, that's like such a basic important thing, so somebody must be paying for that. But actually, yeah, there's some big gaps in that thinking, and I think we need to sort of address how core flexible funding that comes in, whether it's WHO or other governments and non-government institutions, can have a certain earmark set aside for this type of really important research to advance the field.
Great, Ed. Thanks so much to you and to Dr. DeLeo for joining us. That brings us to the end of our time. Thanks to everyone for the wonderful interactive questions. Please keep them coming through our next panels. Really appreciate the insights that you shared, Ed. And with that, I'll hand back over to Robert.
Thank you so much, Shannon, and thank you again to our speakers. That was a fantastic session. We're now going to shift a little bit, and we're going to have now a panel discussion with some of the authors from the themed issue. Shannon has already shared the link to the theme issue in the chat. I would encourage you all to look at this. There was a number of outstanding papers and pieces in this themed issue, so many, in fact. We've selected a few that we wanted to highlight today, and we've selected these across the three components of the operational framework for primary healthcare as conceptualized in Astana. So looking at community engagement, community empowerment, looking at primary care, and looking at multi-sectoral actions for health. And so we have a super lineup of panelists here and lead authors to discuss their papers. We have Soumya Kadandadale from UNICEF in Indonesia. We have Etienne Langlois from the WHO Partnership for Maternal, Newborn, and Child Health. And we have Emma Sachs from the Johns Hopkins School of Public Health. We're going to start with Soumya. We're going to then go to Etienne, and we're going to close with Emma. Each of them are going to speak for about 5 minutes or so to give an overview of some of the main findings of their paper. And then from there, we'll go into questions and answers. So if I can remind everyone to continue with the questions, please continue posting them in the chat. Soumya is, as I said, going to be our first speaker. She's currently the Chief of Health at UNICEF in Indonesia, leading one of the largest programs in the country. In addition to tackling maternal, newborn, and child health issues, She's also initiated new areas of work around mental health and air pollution. Before joining UNICEF, Soumya worked with WHO for about a decade in various positions at different levels of the organization. Soumya, at this point, over to you and looking forward to your presentation.
Thank you very much, Robert, and good morning, good afternoon, good evening to everyone. Very excited to be here and very excited to hear all of the interesting discussion from the previous panelists. Maybe just to get started, if we could, I don't know if the presentation's up, assume it will, so I will continue speaking. So maybe just to get started, a few of us got together to write a little bit around primary healthcare and its link to the whole climate crisis. And essentially, we wanted to try to unpack some of the main elements of primary healthcare as it relates to one of these most pressing and urgent issues of our time. So maybe just to start off with this first slide, you'll see a little bit forecasting of how we might see the increase in susceptibility to malaria across the world as the temperature increases and other factors such as floods, etc., will play a massive role in the coming years. And again, primary healthcare would really be at the front line of responding to these challenges, not just from a communicable disease perspective, as we see in this particular map, but also, as we'll see in subsequent slides, around non-communicable diseases and other sectors and areas that would have a massive impact on the strain in terms of the resources that would be required in terms of the climate crisis as we see this challenge going forward. And it would be particularly devastating to vulnerable groups. We have about 2.3 billion children right now across the world under the age of 18, and this will continue to have massive impacts on groups like children, but also women, migrants, the elderly, etc. So really, this was one of the key reasons and the impetus for why we took on writing up some of this work in this special issue. Next slide, please. As part of the analysis, we did a quick review of the national health sector strategic plans of the G20 countries to see to what extent there might be any understanding or reference to climate issues in these plans. And we found there was only a very cursory reference in only 2 of those that we looked at, in France and in Indonesia. And just to emphasize, this was just, at least we could find the words climate change in these plans. There was very little in terms of an understanding of how it might impact health or the population that's being affected. But at least there was some reference as opposed to the plans of the other countries that was available. And we also looked at the climate plans, so these national adaptation plans that countries work on in order to be able to tackle climate change across their different sectors. And again, there was very little in terms of the broader health systems and the more specific components of primary healthcare that was being addressed. So there's really this disconnect of how we approach primary healthcare and how we approach climate change, even within countries across different sectors. And there's very little being spoken amongst these different worlds, really showing a massive disconnect amongst these issues. Next slide, please. So then we just looked a little bit at unpacking along the 3 pillars of primary healthcare and the sort of effects of climate change as it relates to these 3 components. So again, in terms of the first pillar around primary care and public health interventions, so again, when we're talking about healthcare workers, nurses, midwives, doctors, they really are at the front line of a lot of the challenges that we will be facing and are already facing in many parts of the world. And there's essentially a feedback loop in terms of how this links up to different components. For example, on areas around air pollution, in terms of the specific health effects around undernutrition, for example, but then also all the different actions that the primary care at the primary care level itself that could be undertaken to address these issues, including looking at mitigation, looking at adaptation, looking at how best to reduce the carbon impact itself of primary healthcare, in addition to the effects the primary healthcare systems would be experiencing. Next slide, please. Then this is just another example in terms of the multi-sectoral action. And this one is from a very interesting piece that came out about a year ago around this syndemic between climate change and obesity and malnutrition, undernutrition specifically. And again, we're looking at these very interrelated systems where if we're talking about the specific aspects that are at the forefront of primary healthcare, how they then interplay with elements, for example, of transport, of agriculture, of all of these sectors that are vital and critical to really be able to tackle these different actions and generally lead to essentially co-benefits by really taking on these challenges across the spectrum of the different aspects that would be faced around this area. Next slide, please. And then finally, looking at this whole issue of community empowerment. So this is just very timely because on 20th of November, it's World Children's Day. And in Indonesia, we did a quick poll of about 1,000 young people to understand how they feel about climate change, whether this is something that they're worried about. Most of them are. So unsurprisingly and sadly, this is something that is of a great concern to young people. And many of them actively want to be engaged in terms of being empowered to tackle this issue. And then if we link this in terms of really then looking at this interplay with primary healthcare and referring to what Dr. Ed Kelly said earlier as well about having young leaders around primary healthcare, there's definitely an opportunity in terms of how the communities can come together to really be able to tackle this in a sort of mutually beneficial way. So with that, next slide, please. I'd just like to end with just to thank again everyone. And this is just a map that you might have seen that shows the global temperature rising over the past 100 years. And 2020 is on track to being the hottest year on record. And sadly, 100 years from now, 2020 will probably be the coolest year on record if we continue with this trend. Thank you. Over to you, Robert.
All right, thank you so much for the presentation, Soumya. At this point, we're going to move on now to Etienne. Etienne is an epidemiologist specialized in maternal and child health systems, knowledge translation, and evidence synthesis. At PMNCH, Etienne leads an evidence and knowledge team aiming to synthesize, translate, and enhance impact of policy relevant research on reproductive, maternal, newborn, child, and adolescent health. Etienne, we're looking forward to your presentation. Over to you.
Great, thank you very much, Robert, and I'm delighted to be here. Greetings to all colleagues. So I'll be presenting today the key findings from our paper in our multi-country study that looked at 20 different low and middle income countries. And this is based on case studies that were led by country authors that themselves engaged with numerous stakeholders, including policymakers and communities and really stakeholders grappling with this question of PHC delivery and PHC system strengthening. Next slide, please. So why I focus on policy and systems? I think one of the issues that we're grappling with now with COVID-19 is really this question of adaptation to population needs and adaptation of different service delivery, financing, and governance models. And there's something to be said about primary healthcare being at the center of this adaptation, in the sense that we know that it is at the front line of communities, of vulnerable populations, and that it is adaptive to and responsive to the needs of those communities. We also know that PHC systems are equity enhancing and that they're a fundamental and efficient route to universal health coverage. So that is really the backbone for this study. But what we know, unfortunately, is that in many low and middle income countries, PHC systems are underfunded, under-resourced, and too weak. So we then see suboptimal outcomes in terms of PHC functions and a link with health outcomes in populations. And And what we know is also that the role of evidence, of research to improve things. And I think it's fundamental that we have this conversation today and this week about using evidence to shed a light on some key problems, but also thinking about effective and acceptable solutions moving forward. Next slide, please. So the data source for the study was the 20 premises case studies that the Alliance developed over the last few years. And I'm wearing two hats today. One is as PMNCH and team lead, but the other one is as a scientist for the Alliance when I coordinated this work. And the basis for the study is really to look at cross-country learnings and really shedding a light on some of the challenges, but also some of the mitigation strategies that were implemented and some of the commonalities across different countries. Next slide, please. So while we move to the next slide, one key finding here around PHC financing is, when looking at the 20 countries, what we saw is that in half of them, out-of-pocket expenditures was over 40% of total health expenditure. Now, what we know in terms of trends is that even before COVID-19 hit, we weren't on track vis-a-vis this question of out-of-pocket expenditures. So it was actually rising globally. And of course, this is a critical link to equity. It's linked to catastrophic health expenditures, to increasing poverty. And so when thinking about moving to some of the principles of the Alma-Ata and Astana declarations, equity is really at the forefront. And this question of PHC financing needs to be tackled. Next slide, please. And this is showing other findings, and I'll focus on two issues that are here on the screen. One is on this question of governance and regulation. What we saw in 70% of the countries that we looked at is that the private sector was largely unregulated, and of course this was linked to poor quality of care. Now, in terms of solutions and thinking about how to mitigate this issue, it was interesting to see that in many countries there's actually increasing systems and incentives for to strengthen regulation and to strengthen regulatory compliance, and strategic purchasing, for instance, is one. So somewhat of a silver lining in this question of poor governance. Similarly, there's also a challenge vis-a-vis community participation in this pillar of primary healthcare. And so what we noticed in more than half of the countries that we looked at is that oftentimes, there's community structures that are in place. So you've got the architecture for engagement, but the engagement is just not happening. And so there's a question of power imbalances. There's a question of those bodies not being resourced or not having the power by constitution to actually influence things on the ground. And really, we've seen this is a huge issue, especially where we had a strong privatized sectors, for instance, in Georgia or urban Bangladesh. Now, in terms of solutions and ways of fostering social accountability and improving things vis-a-vis community engagement, there was interesting models around embedding community engagement within accreditation processes and really using regulation mechanisms to foster this question of community empowerment and community engagement. Next slide, please. So this is showing data on the burden of disease, and I'd like to bring your attention to the center of this graph, which is showing the increase from 2000 to 2016 on the deaths that are due to non-communicable diseases. And if you see first of all, it's increasing in all different settings from low to middle income countries, but you see the fastest increase in lower middle income countries. And it speaks then to this challenge of adaptation of health systems and sort of back to this critical function of PHC systems being at the forefront of community needs and needing to adapt. And I think that there's a strong message here in regards to the data and to evidence that is required in this space. to really drive change and to really make sure that we have a conversation around transparency and accountability that is rooted in evidence. But unfortunately, what we saw in many case studies is that we're missing this evidence, and you don't have, PHC sensitive indicators, and you're really sort of missing the country priorities in that space. And so I very much commend this initiative of shedding a light on the impact of PHC research. I think it's also very critical to move towards equity. Understanding what are equity enhancing interventions, for instance, what works, how, in what settings, but also understanding what is essential to move towards universal health coverage. And I'll stop here on this presentation. Thank you, Robert.
Thank you so much, Etienne. Really great presentation. Glad to have your paper as part of this panel. Next up, we have Emma Sachs. Emma is an associate faculty in the Department of International Health at the Johns Hopkins School of Public Health. She's also a consultant for WHO. She's focused on increasing access to quality of pediatric care, specifically in the postnatal period, and in the roles of communities in strengthening health systems. Emma, we're glad to have you with us today. Over to you.
Great, thanks so much, and thanks everyone for joining on this very crucial topic. I'm going to talk about one of the papers in the series that focuses on communities in primary healthcare, and I want to thank not just my esteemed co-authors on this paper, but in the whole supplement and everyone who's been working in this area. Next slide, please. So in our paper, we argue that communities are actually the cornerstone of primary healthcare and not just passive recipients, but really need to be involved and leading in the planning, implementation, and evaluation. And we give examples in the paper of times where this has been done successfully, but we make sort of arguments about how this hasn't necessarily been done globally. It hasn't necessarily been measured in a standardized way, and we still have many challenges in trying to understand the most effective ways of community involvement and leadership, and the ways that we can evaluate sort of the interaction of these communities with the health system. So when we think about primary healthcare, we really need to think beyond just the health facilities and think about the communities and household levels where a lot of health activities, both kind of preventive and curative, are taking place, as well as many of the decisions about healthcare seeking. And I think when we talk about communities, we often think about it sort of as one type of entity, but of course communities are not monolithic and they're not static. So the needs and preferences of communities and community members will change over time. Communities themselves have kind of embedded power dynamics that can also change over time. And I think especially in this sort of time we're living in, we can think that many communities sort of act as the front line for outbreaks and emergencies, and might actually be sort of uniquely placed to make some of the adaptations that are necessary for responding to kind of new epidemiologic threats, and that recognizing that role can be critical. Next slide, please. So one of the things that we elaborate on in the paper is our need to improve our metrics and measurement in this area. And many of the sort of currently used metrics focus on overall coverage and clinical health outcomes, which are, of course, very important. But we also need to be thinking about a number of other kind of aspects, including equity, community ownership, agency, and control over priority setting. And these things might be more difficult to measure, but sometimes can tell us more about the situation of what's going on the ground. And the sort of community involvement needs to be measured at multiple stages. So not just was the community sort of involved in some aspect of the implementation in some minor way, but really thinking about through the entire process, who was involved in formulating the program, who was involved in overseeing various aspects of the program that may even include supervision of staff or approval of various budgets, as well as utilizing and understanding data and allowing the findings to catalyze new changes and improvements in the system. So I think when we kind of think about how to measure this, we have to expand a little bit into areas slightly outside of maybe the traditional way that we think about health systems, because the way that people experience health is multi-sectoral. And so we need to be thinking about how do we understand and measure some of these educational, social, behavioral, and structural interventions, as well as how these change over time. And that makes for some additional complexity to think about how these different pieces interact. And I think where some of these have been measured, it hasn't been done necessarily in a standardized way or a way that we can necessarily see these kinds of changes and dynamism over time. Next slide, please. So in addition to some of the more detailed kind of metrics, we also talk about the need to improve our conceptual and analytic frameworks. And many of the existing frameworks, while I think there have been more and they've been taking community roles into account more and more, still have limited ability to address some of these important community health questions. So as I just mentioned, some of the kind of aspects of the health system that aren't always captured in these kinds of frameworks include things like local governance that you just heard about, and other kinds of intersectoral partnerships. And what we talk about is the need for innovation to better understand and monitor some of these complex dynamics and the social context in which these health systems sit. And as you heard about a little bit before, where many of these things have been measured, it's been done more as a pilot or sort of a small test, maybe a group of facilities in a particular country, but there's been very little kind of evaluation of this at a larger scale. And again, even when that's been done, it hasn't necessarily been standardized. Next slide, please. So while I think we could discuss the particulars of this all day, I will just summarize a little bit here. And just to say that I think many of us would agree that sustainable, effective healthcare programs require collaboration between the formal health sector and communities. And that may include community groups, community members, and kind of different formations. Improving primary healthcare requires a multi-sectoral and holistic approach, and sort of all of these aspects require thinking about a broader way of measuring community involvement. Primary healthcare begins at the household and at the community level. And so when we think about the different layers of measurement that are needed, we can't just start at the door of the health facility. And so I think this challenges us to think about how we can better understand and monitor and measure kind of effective primary healthcare and the roles that communities and community members are playing in strengthening these systems. So finally, health for all requires not just involvement, but leadership from communities. And I think that should give us quite a lot to work with and think about going forward as this agenda gets more attention. And I thank everyone for your time.
Excellent. Thank you, Emma, for the presentation. Thanks also again to Etienne and Soumya. We also have a number of great questions from our participants. Thank you, everyone. Keep putting those in now. What I'm going to do now is pull out a few of them for our panelists and read them out. And then in our remaining 5 minutes, maybe we can go through them. So Soumya, for you, we have a question. I'm a GP from Indonesia. I'm aware that the health system is quite vulnerable, and then the research conducted in Indonesia specifically about PHC is quite small. Not to mention the quality is sometimes poor too. Do you think those factors contribute to challenges in strengthening the health system in Indonesia? Emma, here's a question for you. How feasible is it to involve communities, especially when designing national level programs? And then Etienne, for you, a question. Do you think there is need for large, expensive RCTs in order to provide the largely absent high-grade evidence to back claims we routinely make about PHC? All stakeholders seem bought into the power of PHC, even though the vast majority of our evidence is ecological. Many thanks to your thoughts. At this point, again, we have about 4 or 5 minutes left, so I realize those are all big questions, but I'd like to go back to our panelists now if you'd like to attempt to answer those questions, and maybe also close with any kind of final remarks on PHC and PHC research. Looking forward to hearing your thoughts. Soumya, starting with you.
Great. No, thank you very much for that question. So I think, yeah, indeed, there's definitely some challenges around the availability of primary healthcare research in Indonesia, but that's definitely a changing landscape. And I think particularly over the past few years, I think government partners, the institutions, research institutions have invested a lot to try to address some of that gap. So I think there's definitely a movement, and already, as we heard in this evening's morning session for those of you in Europe, there's already some work that's come out from the discussion today, where Indonesia is one of the countries that was looked at. I think in addition to that, there's different universities in Indonesia that are also trying to build research capacity, particularly for primary healthcare. So I think we're seeing really a shift, and also in terms of the investments that the government itself is making, particularly the Ministry of Health, but also other ministries like Bappenas, the Ministry of Planning for Development. So I think we will start to see more of that going forward, and hopefully conversations like this will add to that space. Thanks very much.
Excellent. Thank you so much, Soumya. Etienne, over to you.
Yeah, thanks, Robert, and great question. I think there's the biomedical model is heavily looked at RCTs, and that's just one component of evidence. I do believe that it's necessary to have them, but it's not sufficient. I think there is great value with primary healthcare to look at complex interventions and using randomized trials to do that, but I think that for questions around multi-sectoral action and community engagement, there's a need for real world evidence that's more around implementation and health systems research that's not necessarily randomized. And preparedness and response, for instance, is something that requires different types of studies and different types of evidence. I think what's required is high quality evidence and high quality research. And for that, we as a community, we have a role to play in strengthening capacities of different colleagues in doing high quality PHC research. Thank you.
Excellent. Thank you very much, Etienne. Emma, over to you.
Thanks. And I think we all recognize that the challenges involved in what we're all trying to do in primary healthcare, and obviously sort of the heterogeneity of communities can increase kind of the difficulty. But I wouldn't let the feasibility stop us from thinking about the ways that we can involve communities at various levels. I think as you heard before, many countries actually have certain structures already in place with some kinds of community organizations or mechanisms for involvement. I think more kind of probing is needed to understand kind of how equitable that representation might be and what the actual kind of participation looks like, and the power imbalances that might exist. And I'll just add also that I think an area probably ripe for additional research is thinking about the balance between sort of additional power and responsibility and burden. And as someone who has spent a lot of time looking at postnatal care and community roles, when we try to shift a lot of the sort of power and decision-making into families and households, we also sometimes add a lot of extra burden. And so I think when we think about the role of communities, we should be keeping in mind kind of where some of those responsibilities and burden lies, and that by ensuring access to facilities alongside trying to bring some of the care into communities, we can, I think, get to that balance a little bit better. But I think that's a critical kind of point. Thanks.
Excellent. Thank you, Emma. It's now 2:30 in Europe, so we're going to need to pull this session to a close. I want to thank our panelists again. Thank you, Emma. Thank you, Etienne. Thank you, Soumya. I want to thank all of the participants, as well as our previous session. Thank you, Shannon, for moderating. Thank you to Ed and Soraya for joining us, as well as to Dr. Ghaffar for getting us started here today. This session is being recorded and will be available on our website after this. So if you missed a session or want to watch again, you're welcome to go to our website and see it. Again, a reminder that this is the first of 3 webinars that are occurring on PHC Research. We hope to see you tomorrow and on Friday, but for today, thank you very much and have a wonderful day.